Afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us today for this webinar. The Trust is pleased to once again partner with Dr. Sarah Smoker Barnwell and Margot Adams Larson to present these telehealth community chats. They have done a tremendous job with this series, and I know I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. I'd also like to take a second to remind you that the CE earned from our chats, as well as the two-part SciPact roundtables, can be used to fulfill SciPact's 3-hour CE requirement for your e-passport renewal. If you're unfamiliar with SciPact, I encourage you to visit their website at www.scipact.org for more information. I hope you enjoy, and I know you will benefit from our telehealth chat today. Please join me in welcoming Dr. Smoker Barnwell and Adams Larson.
Thank you so much, Dr. Martin, and thank you so much to the Trust for hosting us today. I'm Sarah Smoker Barnwell, and I am delighted to be here today with you, Margot Adams Larson.
I'm super excited to be here, and I am just realizing this is our 22nd chat, and it is the 22nd of January. So there's some karma going on today. We've got a lot to chat about, and I'm really interested to dig in.
Great. Well, this is our quarterly check-in where we discuss practical how-to information in telepsychology and sometimes telehealth more broadly, with a strong emphasis on ethical perspective. We have the benefit of some questions submitted in advance, and thank you to those who took the time in our last chat to have some questions entered into the Q&A, as well as those who maybe sent us questions in between chats. We do our best to answer those and try to pull frequently for the topics for this chat from questions from the prior.
And just as a reminder, we're chatting about the practical, the how-to, some of the strategies you might use to answer your very specific questions, but we're probably not going to have a very specific answer for your detailed question. But we're really focused on the ethical perspectives and the clinical thought behind how we navigate some of the challenges or situations that come up related to telehealth and practicing in this kind of new era. So without further ado, I do want to make sure we talk about any disclosures that we might want to make. And one of those is that we really are telehealth enthusiasts. So we do come to the chat with some enthusiasm for the things that we are speaking about. Sarah, some other disclosures you had in mind?
Sure. I always like to mention that I am a trustee with the American Insurance Trust, and we always like to include the disclosure that certainly when you are speaking about technology, things with technology inevitably go amiss. So we'll ask for your grace and kindness should that occur.
And one last disclosure, we are not using slides for this conversational interactive chat. And so if you have a question, drop that in the Q&A box. We'll see that and hope to get to those. And as Sarah mentioned, we do get a lot of questions coming in. So if we don't get to your question today, we will loop it back into a future chats together. So I know we've got a few newsy items, and I will kick it off with just an update in terms of SciPact. And Dr. Martin mentioned there are some resources. You can find that link in the chat as well. But we're up to 40 enacted jurisdictions that will offer SciPact and 39 that are effective currently. And I just want to celebrate this. This is no small feat to have accomplished this. And the timeline in which that was accomplished has been amazing. So continuing to support interjurisdictional practice, and just you can go to the resources that were linked in the SciPact fact sheet to find out more details about that if you're interested. Also, just a shout out to the on demand now for the SciPact conversations that were last month. They're phenomenal. They're packed with awesome information, and if you can find those linked on the Trust as well to review or see those again.
Those were excellent. In additional news, we had some general news about telehealth utilization trends. And notably, there was a recent report from the Agency for Healthcare and Research Quality. Sometimes I hear that called AHRQ, I believe is their acronym. But the point is, they've offered a report that informs us that pediatric telebehavioral health visits have increased 30 times over since 2020. So just they were looking at this long view, since the pandemic and the necessity that it introduced, we've seen a 30-fold increase in pediatric telemental health visits. And I think this is important. I mean, it's interesting, but I think it's important because in the context of a national shortage for pediatric mental health providers, this is a valuable thing for us to be aware of, and particularly if this is something in our practice as psychologists, something we're considering offering in our practice, to understand and benchmark that this is increasingly something we're seeing in standard of care. This is an increasingly common, way for us to serve young people. So I thought it was an exciting trend to share. In a similar vein, with see additional data about telehealth visits generally. So, I think a lot of us have heard or read in the newspaper that, since the peak pandemic, and since the end of the public health emergency in this prior year, we've seen a decrease overall in telehealth visits. So just as a benchmark, I think in the height of things per quarter, we were seeing about 75 million telehealth visits, quite a few. And now it would be about half of that per quarter. But interestingly, telebehavioral health, inclusive of telepsychology, has remained pretty darn steady. And in fact, we see that now over 2/3 of all telehealth visits are behavioral health visits. And I think for me, this really goes back to those early days of recognizing the goodness of fit between behavioral health, psychology, and the telehealth modality. And so I think that this was kind of a nice reminder for me of like why we do this work, access, and the goodness of fit for the nature of the work we do in most practices, not every practice, but that there is a nice match here.
I think it's important too, Sarah, just to celebrate that we've got providers interested in providing that level of telebehavioral health care to folks. And I don't think we would have been there had we not gone through this past several years of learning how to just kind of juxtapose into that.
It's not how we wanted this to be democratized, but it did happen. So yes. So final item in our news for today is that this is a good time of year if you do bill insurance for telehealth appointments to pay attention to any changes the insurance carriers that you bill may have for codes specific to telehealth. This is the time of year when we'll often see new rules and regulations, particularly coming for Center for Medicare and Medicaid Services. And that's always a great resource generally to learn about billing and coding for telehealth. The reason I'm not really digging in and saying, oh, this code or that code is what we all have found is that these types of things tend to be very specific to the insurance carriers we work with. So this is a great time of year to pay attention to those newsletters they send out, to really attend to whether or not we're having claims bounce back, or if our clients report any problems being reimbursed or payments that we might receive directly. This is a great time of year to really pay attention because it is the time of year where we may see changes coming down the pike. Okay, I think that does it for news, Margot, and I think I'm going to pass it over to you to talk a little bit about patient environments.
I am excited to dig into this topic today. We get a lot of questions in the theme of understanding just what are those privacy requirements, but also how to help navigate those conversations with patients. And inevitably, patients are joining our telehealth sessions from some venues we just could not have imagined 10 years ago, from parked cars, maybe driving cars. We have folks logging in from their work sites, from all sorts of places we might not have anticipated or expected. And so this question about how to have a conversation with patients about the privacy of the environment in which they're located, receiving the care that we are providing, I think is really key. And the beginning of that conversation is actually in our consent form before services ever start, and really outlining the things that make a session private, comfortable, safe, and what types of areas or spaces or locations that might be. And granted, there might be some really good reasons why visiting somebody who is in their car, in their driveway, away from their kids and family in the house, and having privacy in that type of setting might be best for that specific patient or client, but might not be the situation we want for a different patient or client. And so having thought through this in terms of what you put together in your consent form, what the concepts are, and the reasons for that private, safe, comfortable space, I think can go a long way for helping patients really understand the distinction that this isn't exactly the same as medical telecare. And it's also not the same as just jumping on with your best friend to have a conversation about what you might want to vent about, and really structuring the boundaries of that professional relationship, and also honoring the background, the environments in which the delivery of care has been demonstrated to be effective. And so, again, thinking through what are kind of the features, the qualities of the environment that make a space private, safe, and comfortable for a client, that they may be receiving that telecare. Also thinking about how can you talk about this within your consent form for telehealth ahead of when you're visiting with them. And that consent form then forms the checklist or the conversational talking points and guides that you will have with them before you ever embark on care as you're going through the consenting process. Again, I think it's helpful to think about the idea here that patients are always appropriate to receive care, meaning that we don't want to phrase the language for telehealth being, you can only do care if this is the circumstance, because patients are certainly, they have the right to receive care. How that care is delivered and the best mechanism and the best medium for delivering that care is something we want to contemplate and think about as we're navigating that consenting process. We also want to think about the safety aspects of the perhaps usual space you might be visiting where your patient is located, and how accessible emergency or crisis intervention is in that location, and making sure that you have kind of a routine process, a routine conversation that you have at the start of every session that can review who's in the environment, where are they located, what is the license plate of the vehicle they might be sitting in, or if they're in an office building, where is it located, what floor, so that if there needs to be a more boots on the ground intervention at that time, you have information in order to direct that better. I also think there's a distinction of understanding what the boundaries of good clinical ethical practice is and what the preferences are in terms of patients navigating their life and having intervention coming into that. And so just because telehealth might be a preference for a client does not necessarily mean that today, in the circumstance that they're logging in from, is the most optimal for that. And so having these conversations ahead of time, planning ahead if they're traveling or in a different location, or that that's going to happen, you can have that conversation ahead of time to help navigate what you might need to ensure you have in place as a provider to be providing the best care in that circumstance. And finally, related to kind of the environment the patient is in, is how they're accessing, what cell service, Wi-Fi service, etc. The technology they're utilizing to access that video conferencing at that time. It's important to understand kind of how they're navigating that and provide some education as to what's the most confidential, what might not be confidential, and having some conversation of what makes sense given the circumstances for that particular situation or time. Light and sound inevitably become issues, no matter where the situation is in terms of technology. Sometimes the light's too bright, the sound isn't working quite right, and making sure to have a conversations and not avoid it or ignore it so that the care that you're delivering can be most optimally received at that time. The last thing I'll say on this topic is making sure that your documentation surrounding your session includes all of these things that we've just talked about in terms of noting where the patient is located, how you determined that they were alone or that this was a private, safe, and comfortable space for them. If something might have influenced the privacy, comfort, or safety of that space, how that might have impacted care or impacted their engagement level within the session. Those are all really important aspects to document within your session note as well. Making this a routine, that's just a common thing as you're starting session, it just seems like you do it all the time, helps your clients feel like you do this all the time in terms of checking in. It's not something special for them in that circumstance, and it becomes part of the routine of that telehealth visit. And I think just sets the boundary and the structure for your care delivery to have a more consistent tone. And so in that, you've got some routines in place. You've also got your routine of documentation, and it really helps support the patient's understanding of the importance of the privacy, confidentiality, safety, and comfort of the space that they're receiving care and the time that they're accessing the telehealth visit. So
We had some great questions, and one of them related to some of the things you were saying.
Okay.
Had someone ask a question, well, okay, well, what if I start a session and someone isn't in an appropriate, private, secure place? Can I end the session? And I guess I have my own thoughts, but I'm curious, what do you think?
Yeah, I think having conversation through this, so stepping away from the intervention component and identifying, gosh, it seems like there might be someone else there, or, I see maybe your roommate came back unexpectedly, let's pause for a moment and be reminded about, what our agreements are in terms of care delivery and what works best, what doesn't work best, we can reschedule. I think depending on the content, depending on the circumstance, stopping kind of the intervention phase and moving into kind of administrative conversation about, can we pause? Do we need to reschedule? That can lead you to having a better understanding of what that circumstance might be.
It's a great point, because at the end of the day, we are the ones accountable to HIPAA. We are the ones who are accountable for the privacy and security of the meeting. And so, this is something I like to address in my informed consent documentation, and specifically who is financially accountable. Because if your roommate comes in the middle and we can no longer have a private secure session, we're having to reschedule it, well, who pays for that session? Is that, and how do we think about that? This was me trying perhaps inelegantly to mention that we have some great questions about informed consent. Specifically, folks asked if there should be a unique informed consent for telepsychology, as well as thinking about doing interjurisdictional work through SIPACT, and how do you think about those interjurisdictional conflicts? And I wanted to mention the first one. I love it when an answer is like, I could say yes or no. Yes, you should have a separate informed consent document for telepsychology. And I'll mention that the trust has a great template that they offer that goes through the components you would want to have in that document, some really helpful language. I think it is really valuable to have it distinct and really to help folks conceptualize this as a distinct service. Now, some folks have telepsychology only practices and they say, well, that's always part of my standard documentation. That's just fine. It does get complicated, when we start going in between jurisdictions, because there may be, and we're going to talk about this in a little bit, there may be different rules in those jurisdictions, inclusive of things like age of consent or those types of things we would want to be sure to cover in our informed consent. And I saw a question that said, well, gosh, do we have to, consult an attorney for every single one? My general counsel is it is a good idea, to speak to a healthcare attorney. I think I agree that it can get quite costly. I think there are some templates that can help us on our way. The trust has a good informed consent template as well as the telepsychology template. I'm going to put in the chat a resource from one of our APA divisions. It was actually, I believe, a collaboration between two of our APA divisions that come from Division 31, that has some state-specific guidance on records, what type of records would we, want to see, et cetera. Now, that's not the same as informed consent, but I think it, to me, helps me understand a little bit about some of the differences we see among jurisdictions. This is a great place where I would always take a time, maybe talk to my trust advocate and reach out and schedule a call with them. But generally speaking, you want to really understand the rules of the jurisdictions you serve, decide in advance how you are going to resolve any foreseeable conflicts, things like reporting mandates or records retention or, age of consent, all great examples, and document that very thoroughly. I do think it's good counsel, to have that legal counsel, but I think the more we can do in advance and have our documentation in good order and have looked at resources in advance, we're going to abbreviate the time that we have to have a professional helping us and hopefully reduce the bill. Margo, anything you'd add to that?
Yeah, I love a couple things that you said. One, that, despite the patient perspective, it's still our obligation. And I think I absolutely will ditto your comment about do your homework ahead of time, because that can reduce attorney review time. The trust in the past has had some really awesome resources as well that were jurisdiction specific. And so I think we can find those online through their library and guide. I see they posted that reference in the chat. But if you are practicing through SIPAC and you are practicing into a different jurisdiction, you really need to be thinking about, with your kind of clinical ethical hat on, if I were licensed in that jurisdiction, what are the requirements, consent-wise, et cetera? And you have to practice in that manner, even though you're sitting in your own jurisdiction and you have also those kinds of requirements as well. So I think it is well worth spending your own homework time to do a due diligence and a detailed review so that you know what all of those aspects are that you need to navigate through specific to that different jurisdiction.
And it's good to set a calendar reminder to update that. I try to do it at least once a year. It's not my favorite to do item, if I'm honest, but, I do find that things change. And so, once you get it down as to the resources you consult and how you think about, how you're thinking about the jurisdictions that you serve, I think the task takes less time, the more you do it. But I think it's notable that it's not a one and done. It's the type of thing that we update along with our other documentation, regarding practices and policies of our practice.
And a lot of the psychological organizations within the other jurisdictions are actually posting some of this information on their website. So that is another resource to look to. If you're not a member, you might not have all of the deep access, but you might become a member to access that if it's a common place that you're practicing.
I saw there's so many good questions today. Thank you so much.
I
think it's an embarrassment of riches. Should we do one more before we?
Sure, yes.
Can't not do this one. I previously contracted with a telehealth company that recorded all sessions, audio only. Patients signed consent for this, but I felt uncomfortable with it. Comments. And my comment is, I think you're very smart. I think, I want to acknowledge that this is a practice. So it's not as if this is an unheard of practice and oh my goodness, I've never heard of such a thing. That, yes, that does happen. But I think anytime patient information is recorded, we have to ask the questions, why, where is it going, who has access to it, what happens in case of a breach, and how will I know that information? Because my license, indicates, HIPAA security rule indicates that I have some obligations to protecting patient information resulting from my care, and so I think that this would another one where I'd probably seek some guidance. I might call my trust advocate, or if I have a healthcare attorney, I'd ask them the question. But I think you're right to have to seek follow-up on this, because again, while it's not an unheard of practice, and I'm really glad they're having people sign consents for this, I would want to understand what my obligations as a psychologist were, when I may not be in control of what happens to the data. So I'm always want to take extra caution and really investigate those circumstances where I may be on the hook for something I actually don't have any say in.
I guess I would also wonder if you, as the psychologist, signed a consent for them to keep your audio as well. I didn't hear that as part of the question, but that may be something to consider.
With enough time, there will someday be a Margot and Sarah AI chatbot, who will be doing these chats, because there's just so much recording of us. They will, so yeah, I mean, is my data a training model, for your relational agent? I'd have questions. All right, those are my questions, not everyone's. All right, let's get back, because last time we had our chat 21, we talked about the content of records and documentation. So, what we want to document, particularly as it applies to HIPAA requirements and as it applies to often insurance requirements. But we received some questions that were great questions about the storage and treatment of those records, and wanted to dig into that today. Now, of course, we have guidance regarding appropriate storage, retention, and destruction of records that comes at many levels. At the professional level, we have guidance such as the American Psychological Association Trust and ASPPB Joint Task Force telepsychology guidelines, and the APA record keeping guidelines. Both of those in review currently and will be updated. But we have some guidelines specific to psychologists saying this is how we think about record keeping, and this is how we think about telepsychology record keeping. We will have jurisdictional level guidance. So the state, territory, province that we practice in, oftentimes our board will give us guidance regarding things like record retention. And we were just saying a moment ago, this can vary across jurisdictions. So for example, how long it's recommended you keep your records is a piece of information that might be different jurisdiction to jurisdiction. It's really important for us to know within our jurisdiction as well as any other jurisdiction we serve. And then, we have federal guidelines, and perhaps the most famous of which would be our HIPAA, the health, oh my goodness, I'm having a moment. Health Information Portability and Accountability Act.
Mm-hmm.
Okay. Which of course has our privacy and our security rule. The privacy rule generally saying, we can't go telling people the information we are told, and we keep information private and confidential. And the security rule indicating that we have an obligation towards the maintenance of our records. And that includes what they call protected health information, or PHI is an acronym probably many of us have heard. And that's that identifiable information related to patient care. I think we generally all have maybe heard of PHI, or are aware that, we shouldn't be telling people our patients' names or where they live or social security numbers. But there's this whole other subset of electronic PHI, or ePHI, some of which I know I found surprising. So things like email addresses or IP addresses indicating where a computer lives, on the internet, URLs, things like that, more technical information, which also falls under the category of PHI, and that HIPAA says we need to be thoughtful about the security of. And that is like all fine and good, but I'm a psychologist, I'm not a technologist. And so, I think, Margot, you and I talked a little bit, kind of like a best practice roundup, how do we manage our records in ways that are consistent with our obligations and our ethics, but also that are straightforward and easily managed and not technical to the place of being difficult or obtuse. So, we wanted to start off talking about how you store your records. And this is probably the biggest thing, where are you putting this information at your documentation, your notes, assessments you may do. And I think that goes back to a recommendation we make on almost every chat, which is identifying practices. And if we are using technology products that are designed for healthcare. Because there are recommendations in HIPAA regarding encryption, and there are recommendations regarding electronic record keeping. So this notion that we are finding a way to store things electronically in a way that uses encryption. Now, again, I'm not someone who's an expert on encryption, so I like to make a partnership with a company that thinks about these things. I happen to use an electronic health record company. It's designed for mental health practitioners. It gives that business associates agreement, that contract that says, we understand that you have to follow HIPAA and we follow it too. And if there are any problems, we are obliged to tell you about them. So that BAA tells me that I am making a good partnership that will store my records in a way that aligns with my requirements and my ethical obligations. So, some people may use cloud storage. And again, there are products that are designed for healthcare that use that appropriate level of encryption. I know there are folks who may store them on a computer. And I really want to encourage, if you are doing that, making sure that you do have encryption and robust passwords in place. The password that's not password. And a lot of folks I know have said, like, well, gosh, what's a robust password? That word gets used a lot. What does that actually mean? And I encourage folks to look at the National Institute for Standards and Technology. They have guidance for all kinds of things, inclusive of creating robust passwords, inclusive of thinking about encryption for your records, and inclusive of deleting records and destroying and purging information. Because this is kind of the last piece to me, is we choose products designed for healthcare that store our records ethically. And then when we change our hardware, like our phone or our computer or our tablet, when we change our software, like a new program that we use to store our electronic records, that we remember we still have an obligation to those records and that information that might be on a piece of hardware or software that we've previously used. So again, that National Institute for Standards and Technology gives us some guidance on sanitization, destruction, and purging of those records. So, this I think can be for things like when we close our practice, or if we retire, or if we're, transitioning someone's care, but it's also like if I get a new iPhone, it's still relevant. I want to think about what information, that was my patient's EPHI or PHI, came into contact with that device or that software program, because I'm going to need a plan for how to dispose of that. I encourage folks to document that plan, have a recorded copy for yourself. And again, if you need some technical guidance and the nitty-gritty how-tos, know those resources like NIST, National Institute for Standards and Technology, that can help us kind of dig into those details.
Oh, there's a lot to cover there, Sarah, but I think it's so important to keep in mind that these policies and standards have been put in place for both patient privacy, security, confidentiality perspectives, as well as the navigation and management from a practice management standpoint. You could lug a lot of documents around for a very long time, but at some point they become irrelevant, so to speak, because they're old, they're not necessarily, they're things that may have been shared elsewhere in terms of other healthcare organizations or other providers, but they may not even capture, what's the current needs of what your practice is or the patient requirements at that time. So we had a question regarding keeping records. Is it really wise to destroy them? This person has had patients come back after a decade and a half later and addressing, can we address how to destroy or shred those type of documents? And I think just speaking into that a little bit in more detail in terms of those disposal approaches and or the reasons why the old records might not be as useful as we think.
Right. And, the law dictates minimum, but I'm not aware of, and, correct me if I'm wrong, I'm not aware of maximum. So, there's a minimum record keeping standard, which says hey, you have to keep the records for this long in case someone returns to care, but I think there is this concept that many of us do retain records, beyond that. For me, and we're going to talk about this a little bit more today, when we are closing a practice, that in particular, we're thinking about how to manage those records. And, some of us may work for organizations or institutions that have archival plans for how to handle those. But if we are an independent practitioner, we may elect to destroy, purge, or sanitize those records, as part of our closure of our practice. I think it's the exact type of thing we want to discuss with our healthcare attorney, because again, this varies jurisdiction to jurisdiction, and what is recommended in one state may not be what's recommended in the next state, which is why we don't give like a always do this, sort of guidance on these chats. But I think having awareness that we have a minimum to keep them, and that we're going to want to have a plan for what to do with those records, whether that is some type of archival process that we know they will be safeguarded and appropriately treated, or, if we are destroying those records. So having some sort of plan that is aligned with our jurisdictional guidance and ethics.
And I think understanding that those records exist, not just within either the paper or the digital file that you may be storing them in, but they also exist in how you acquired them, by a fax machine, for example, or a scanner or a printer. There are a lot of footprints that records have, digital footprints, that when we're talking about disposal of those records, we're also talking about making sure those digital footprints have also been destroyed appropriately. And I would just add a comment, and somebody noted in the question and answer that in Kentucky there is a destruction expectation, and so there are some requirements around that. Oftentimes, employers or agencies, or particularly if you're working for a state government agency, will also have a records retention policy that speaks specifically to when the record's old and when it should be destroyed. So those are other areas to check into as well. Boy, we've got a lot of great questions. I don't know if you spied any further as you were scanning.
You here, talking
All right.
about other types of technologies, that are still telehealth technologies, like email, text, faxes, that we send one another, and do I need to have consent language around this? Was one of the questions. And my answer would be, it's a great question. And I would say, yes. I'll say in my standard informed consent document, I have language on any technology I might use or not use, and I articulate that, if I use secure messaging, if I use email, if I use text, if I use a fax machine, and it's not pages and pages and reams of, paper. This is a paragraph or two that benchmarks expectations, explains the type of product I use, and outlines appropriate use. So for example, I may articulate, well, if you have an administrative question, you can use the secure messaging portal, and let's talk about appointment time, or if you need to reschedule, that's just fine. But, that's not the place to put emergent information. I personally discourage texting. I don't like to text in my practice. That's my personal choice. I think there are many challenges to privacy and confidentiality, and it's just not something I like to do. Other people do it, and that's, I think, when done well, can be done well. Again, we're thinking about products that offer some encryption. We're thinking about behavioral practices that prevent that information from easily being seen on our phone screen. But that's the type of thing that I might put in my informed consent document and explicitly say, I prefer not to text. And if you did text, this is what's going to happen. I'm going to talk to you at your next scheduled session about it. Now, of course, if emergent information comes in a text, which is definitely not what we're asking for, we're going to respond to that, and we're going to let folks know. So again, that's in my informed consent document, that if I were to receive information that's outside of what's agreed upon, I would seek to confirm it with my client. And, again, thinking through those issues, because I think there's good research that says when we get into trouble, when we see complaints, are often when people are surprised, when things don't go the way they expected them to go, when they felt they weren't apprised of the rules, and no one's memory is perfect. So the more we have these things written down, and we can point back and say, well, we did discuss this, and I got your signature on this. And I think we well position ourselves for success.
I can't agree more. I think the more we document for ourselves and have a process that we can look to in a routine manner and make sure we're updating that, and being consistent with our implementation of it, it becomes a good habit and an ease for the flow of what we're doing in terms of our practice. I'm looking at the time, Sarah, and we've got a couple kind of a back-to-back information coming on closing a telehealth practice and thinking through the ethical considerations that might be unique to that. And then a little bit of follow-up in terms of, life after that practice. So let's move into that real quick before we run out of time.
Well, we already touched a bit on record keeping. And I think when we're thinking about some of the unique ethical considerations of closing a telehealth practice, to me, that's very front and center. Really being cognizant of minimum and maximum, retention guidance specific to our jurisdiction or our organization that we may work in. I know I came up in the VA system, and it had very specific guidance regarding records and its treatment. So it is both your jurisdiction, your license, but also, where you work, because there may be specific policies that are intersectional. Thinking through how we would dispose of data, and that includes hardware, software. We don't just want to delete some files and take it all down to the technology recycling center, or sell it on eBay or whatever, because there are ways that that information can still be recovered. And so this is where really understanding how you truly purge data from hardware and software. And again, there are guides that will walk us through, but just we as psychologists having awareness that just because I delete something off my desktop doesn't mean it's gone forever, and that there are programs I can run that truly reset a computer or a phone and really do wipe all the information off it and make it so that I could give it to someone else or recycle it or whatever I choose to do. In a slightly darker tone, as we talked about some of these themes, Margaret, you and I said, well, we can't really talk about closing a telehealth practice without talking about practice wills. And this very relevant again to records access. So in case you're not familiar, a practice will is a comprehensive document that has a detailed plan for what happens in the case of my incapacitability, unavailability, or even death. What happens to my patients? What happens to my records? What happens to all those chairs in the waiting room, and so forth? How would my practice be handled in a way ethically aligned with the best interest of my patients and my obligations as a psychologist? So we want to think about support, containment, and ethical management of clients and informing them and helping them decide what they're going to do next for their care. We want to terminate ethically and responsibly those aspects of our practice that require confidentiality to be preserved, or our specialist knowledge, and expertise, make sure that's transferred appropriately. So records, going to a new practitioner. Again, with this idea of strict preservation of confidentiality, because that's really integral to our therapeutic alliance, and that really is doing right, by our patients. This is another area where it's a really good idea to consult with a healthcare attorney. I'm sorry, this is like, this is a go-to today, but it's a good idea, to put this in place. Someone that has a specialty practice in this area. And again, we can ask our risk managers, like our advocate service and others, for some guidance, but this is also a good place to identify a healthcare attorney. We want to make sure that we are cultivating a list with our client information and contact details, any specific risk factors, that would be unique to those clients in consideration of transfer of care. Do you need a specialist in this area? Are there emergent health concerns, so forth? A plan for how we would transition care to clients. This is a really good idea to think about in advance. This is not something you want to be caught unawares with a whole panel and no idea where they could go, if I was not available for their care. A plan for secure transfer of records and documents. This is where I think electronic health records do shine, that many of them do have the capacity to integrate with directives from a practice will. Again, that's something that has to be done in advance, but there are secure confidential ways for that information to be communicated electronically. That makes me a lot more comfortable than the idea of something being printed out and handed over. We want to have a plan for our records disposal, which, by the way, is something we want to have anyway, outside of a practice will. And it's recommended that we choose 1 to 2 clinical executors. And often those are going to be other experienced psychologists who know about practice wills, who know about practice, and who understand these types of issues and are committed to helping in this emergent circumstance. Again, this is the type of thing you want to talk about before and not surprise someone with letting them know they're the executor for your clinical will. So it's a good advanced conversation. And then if you do have in-person assets, and management of your assets, or I suppose your hardware, your software, again, a disposal plan for how to get that information out of that hardware, that software, before it is disposed of. So if and if you have a telehealth only practice, and I think this is specific to telepsychology, choose executors who know telepsychology. Because if I chose 2 clinical executors who are wonderful established psychologists, but they'd never done a telepsychology appointment, and they were managing my practice as part of my practice, well, that would be a lot to ask, because they wouldn't be as familiar with some of the mechanisms, some of the hardware, some of the software. I think that someone who knew that world would be better positioned to help in that circumstance. And I think we want to especially consider and predict challenges for care transition for those telepsychology patients that aren't local. Again, this is really relevant if you have an interjurisdictional practice. So thinking in advance about how would I transition care ethically, quickly, if I'm not, in a practice with 20 other psychologists, and they're all local and we all know each other, I'm going to try to find resources either that similarly can be working remotely or that are local to where the patient is. So that's, it's our sadder topic for today, but really important for good ethical practice.
And we don't want to end on that note. I
Okay.
think thinking about there are other reasons when a practice might close, for example, to go off and enjoy retirement. And so we figured we'd put the retirement part of the conversation towards the end so we can at least be assured of a bit more of an upbeating note here. But all of the things that you just talked about, Sarah, are the exact same process in terms of if you're thinking of closing a practice in terms of retirement, that, there's certainly a few other considerations, but all of the ones that you mentioned are the things that we want to consider to, as we're transitioning out of practice, that we have some close colleagues that we can have conversations with in terms of this plan ahead of time, but also who would be open to, taking on that oversight of the records that need to be retained for a certain length of time, even though they're not their records. But having that supportive collegial community is really so key. And I know it is a challenge for many folks, particularly as we're thinking about the telehealth community, because a lot of us do this because of remote areas and not having colleagues, geographically closely located. And so thinking about how you can cultivate that community for yourself and also kind of maybe inspire others in your community to have these conversations. I think if you're thinking there's a comfort in being in a large institutional practice or working for a health system or a governmental system where you may be not the manager, so to speak, or controller of those records in particular, it's really important to ensure that there is a psychological, clinical, ethical mindset around the management of those records. And I recall decades ago when some of the first electronic health records were entering medical health systems, and I was working in a large health system, the idea of what had to happen to secure a psychology note as opposed to a medical note, because there are different levels, hadn't even been thought about by the organization. So even though there's a lot more breadth in terms of support there, I think don't assume that whoever's in charge of the records understands what those psychological obligations are after you're done practicing. I know as we were having this conversation, I kind of had a flash about maybe a durable power of attorney is something you want to at least understand what can happen. And not that it is specifically relevant to a practice will or a professional will. Anybody that you have as a durable power of attorney may actually inadvertently have access to the things that go on in your practice. And so it's just something you want to word carefully and be wise about and understand fully the implications, not just of your own personal side of the world, but how that might end up being something that overlays into your professional world unexpectedly. And again, having those conversations well in advance of needing to have the conversations is probably some of the best life lessons that we can talk about. Cleansing your technology after retirement is also something you want to contemplate. All of the things that Sarah talked about in terms of appropriate destruction of some of those digital footprints. If you're planning to keep your laptop after you're done working and it's just you and you're keeping your laptop, you want to have it cleansed and start fresh so that you're not having all of that HIPAA confidential type digital footprint following you into retirement. And you can do that and still use the same hardware, but you want to make sure you have a certificate that the processes have been complete and that data has been removed. And finally, I wanted to end on the note of saying there's a whole world out there of once you are done providing service to clients or patients in terms of your retirement and practice time, that there's still a world of being engaged with your professional communities, to volunteer for things, to help out and give talks at, perhaps psychology classes, to be a member of an organizational board or a mentor to an early career psychologist. There's a lot of ways to still stay connected without having to feel those heavy obligations of practice and all of the things that we've just been talking about in terms of the data, the disposal, the carrying along of records and things of that nature. So there's a world out there after practice, should you choose to engage.
Well, that is a happier note. So I think we're gonna have time for one more question. Can we get away with?
I love it. I love
There's
it.
one that's one of my favorites was cars. And someone said, I am concerned, said, when we talk about safety in telehealth, I'm very concerned about patients in their car. I do not ever accept driving during our session because it's a risk management issue. And it introduces a great deal of distraction. And I could not agree more. I think that if you told me when I started seeing my first telehealth patients in 2000, that I'd be working in cars, I wouldn't have believed it. Generally speaking, I think we can be creatively flexible in seeing our patients in unique locations, provided we can ensure they're private and confidential, they're physically safe, and we can get emergency services there. So to me, a car parked in a driveway where I know where to send emergency services is quite a different thing than someone's driving distracted, hither and dither. So I share your concerns, and I would say parked car at an identified location is quite different than somebody on the go. Well, I see Dr. Martin has joined us, so I think we are at that time of the webinar. Thank you so much for having us, and we will turn it back over to Dr. Martin.
Sure, I certainly want to thank you very much. I'd like to add one thing to your discussion about closing a telehealth practice. We often, I think you gave wonderful guidance, good risk management, good protection of the patient or client. What we often don't talk about, though, is what is your responsibility if you are the noted psychologist to take over or close out a practice of someone? And I think that one can deduce from what you went over what that role is, but it certainly is incumbent upon psychologists who have agreed to take over a practice or to close it in the event of an emergency or whatever, that there are certain things that you need to be aware of before accepting that responsibility and to understand clearly what it involves. Again, our risk managers could be very helpful in that. I don't want to dissuade people from that, but we often don't talk about what they need to know and how proactive they need to be instead of waiting until some emergency occurs. Know up front what it is you need to know and how you can help your colleague that you're taking care of in the closure of their practice.